And thank you everybody for your attention. So when I looked through this topic and I imagined myself what would be your expectations for a session like this in 15 minutes and what I could share with you. So let me just dive in very quickly. Not sure why it's not moving. Okay. You might have seen this particular picture every other month or every second month or every fifth month in your practices. But luckily, this hasn't been a regular occurrence anymore. And if we do see something like this, we are actually quite shocked. And a lot has happened in this country that has brought us to the point where we don't see these levels of morbid severe acutely malnourished children, the kwashiorkor, the marasmic kwash, and the septic skin lesions, and then the xerophthalmia and the vitamin A deficiencies. So I just wanted to just start off by saying that we're going to focus in these 3 sessions today on the clinical case management, which essentially is how processes of care are geared and engineered in such a way that they focus on the individual care. And we're not going to focus on how the systems are set up on facilitating and enabling that process to happen. And I'm also making some assumptions during this setup that you are all familiar with the terminologies, the concepts, the pathophysiology, the previous guidelines that have happened, and also the tools that came along with them and the data reporting systems as well. But one key question I think you probably all, including myself, was asking was that what really has changed and why is it so important now? So let's get into that. As a way of you getting engaged into this and getting a warm-up session with us, I just wanted us to answer these 5 questions. And if you have the opportunity to write in the text box, please do so now for the next 20 seconds and maybe take a screenshot of these questions so that you can keep answering as we move along. So first question, how many SAM cases did you identify using anthropometric failure, clinical features, or nutritional edema in the last month? How many SAM deaths occurred in your facility? How many SAM deaths occur in your facility every month on average? What was your case fatality rate during the worst month ever? And how would you explain such a high case fatality rate, especially if it's above 10%? And why did you have a case fatality rate less than 5 in some of the months? So it'd be a good way of actually revising our previous guidelines as well in the same way. So I want to achieve 3 things, right? One, let's go through the changes that have occurred in the WHO guidelines since 2013 update and how they've been incorporated into the 2023 guidelines in terms of the broader spectrum of coverage of the SAM and the prevention aspects. And then how South Africa has actually adapted and adopted some of these standard treatment approaches based on the grade and recommendation system that WHO uses. And I'll cover some of the applications and especially some controversies that are related or still remaining in there. So what spurred all of these after a decade, 2013 to 2023, a decade later? In fact, things in SAM actually move decades. They don't move every year. They take a while to actually get us to where we need to be. South Africa is a signatory to the World Health Assembly of 2012 resolution that we need to reduce the prevalence of acute malnutrition and the incidence of acute malnutrition to less than 1% of the under 5 population. And this is now covered in the amendments and updates that speak to the 2030 SDG targets on the Global Action Plan on Child Wasting of 2020. This particular guideline expands its scope to prevention and focuses its attention on what happens after inpatient care, the post-exit care, and specifically targets the under 6 months. It used to be called MAMI, Management of Acute Malnutrition in Infants before, but now they've just incorporated this into one recommended set of guidelines. South Africa has adopted a lot of these recommendations. So what are the 4 main changes that have occurred? So if you're asking yourself, what is it that has changed? So these are the 4 main areas of focus. They've integrated health, nutrition, and development assessments, especially in the first 6 months of life, It's not like it's new to us. We, as child health practitioners and as pediatricians, are very familiar that how the three elements are interlinked. The mother-infant diet care for under 6 months, this type of recognition has mainly been spurred on by understanding the relationship between mother and child in the context of HIV and the lessons learned through that program. You can't separate the two, especially in the first 6 months. And then risk stratified support for moderate wasting. We had very little guidance on moderate wasting for a while now, and a lot of our previous guidelines spoke about moderate wasting and had some recommendations, but this time around, they've sort of become more nuanced based on resource allocation. Otherwise, we'll bust the budget on supplementary feeding. The last one is RUTF for SAM. And I think this is not any different from the previous year's recommendations. It's just now that it should become available as part of an outreach program for children that are being managed in the ambulatory phases of the recovery period. So I did a crosswalk of the 2023 WHO and the SAM IMAM guidelines. And just to be clear, one thing is that the SAM IMAM 2024 guidelines the South African IMAM 2024 guidelines are not publicly available and should not be advertised as available because it's still embargoed in the National Department of Health, but we've had permission to actually look through them and discuss the upcoming guidelines when they get released in the next couple of weeks to a few months' time. They are ready and they're actually waiting for signatures. So let's just walk through some of these aspects of the changes that happened and how they align with the WHO and where they depart from the WHO. So if you remember very carefully, the South African IMAM 2015 guideline was actually a working document, and it included the care of the under 6 months quite clearly and distinctly. And the KZN guidelines as well have quite a established set of recommendations for the under 6 months. But the focus has now become, how do we prevent acute malnutrition in this vulnerable population to start off with? And you will hear from my colleagues who are going to be speaking a bit later, how this has actually changed the epidemiology of SAM away from the peak age of about 10 months to 18 months to bringing it closer to 6 months as a median age group. Some terminology has been removed and has been standardized now. We talk about the continuum of wasting and nutritional edema rather than just syndromic attachments of names such as SAM and MAM. They are used specifically for nutritional status classification, but we all understand that this is a continuum. South Africa has retained this, but sometimes we've, in the guidelines, we've actually referred to them with distinct labels, so that we don't deviate from the previous guidelines and we stick to the nomenclature. Diagnostic criteria, I think this one here, specifically for the under 6 months, we are now using MUAC, and I remember the time when we were told not to use MUAC under 6 months. Now we have one, and the weight for length under -2, feeding issues, and then looking carefully at maternal illnesses. South Africa has predominantly just accepted that as well, and added issues like edema, and if the child is under -2, has complications, or using MUAC as a admission criteria. What is clear then from here is that once the patient has been identified, classified, and then put into one of the assessment categories, you decide on where the patient is going to receive care, inpatient or outpatient. And it turns out that we've agreed, as in South Africa, that predominantly we will try to keep all sick SAM children or acutely malnourished children through a criteria that we have adopted, that is in the IMCI, the ETAT, and then doing the appetite test, and then checking for social circumstances for reliability of the outpatient care. If it is not reliable, then we will admit. What became clear out of this was that we needed to cast a wider net so that we capture many at risk and those who are already acutely malnourished children. So the discharge criteria, according to WHO, was quite strict, needed you to at least reach the 12.5 mark or a weight for length above -2 for at least 2 weeks and had no edema. South Africa opted to be a little generous, whichever one comes first, whichever anthropometric indicator comes first, and that would be the one that would be used. Routine antibiotics hasn't changed. Vitamin A has changed because we don't give any more stat doses, a high dose, routine high dose. We use the hydrolyzed F75, F100, or the RUTF. They have high doses of vitamin A already in them. In terms of caloric requirements for the rehab phase, we have stipulated a very specific range of 150 to 185 kilocalories per kg per day. WHO has given a broader range, and I think that is just to accommodate others as well. Where I think we need to start looking at is community strategies. We haven't developed them as much as other African countries have and other Southeast Asian countries. And the biggest driver for this is actually the demand for higher coverage for SAM. And we are only sitting at currently at 8% detection rates for SAM. That means 92% of children with SAM are still, not identified. The rest of the recommendations are very similar. We've kept to the 10 steps. We haven't changed that at all, and I think we've just adopted some of the 2015 recommendations that we had made in 2015 and continued with that. I believe, and I've been told by National Department of Health, that these 2024 guidelines actually came about through a multi-stakeholder engagement with all 9 provinces, with consultation with some pediatricians and some GCSTs as well, and some nurses on the primary healthcare side to make them happen. Where is all matured into now? If you go to this website and on the WHO, you will see all of this neatly summarized for us to understand why there is a shift in the concept, in the range of definitions that are inclusive of the most vulnerable ones and those that are likely to become SAM or acutely malnourished down the line, and sort of bringing the thinking around prevention and then also management. South Africa went a step forward in the IMAM guidelines of 2024 by including some strict indicators, which are now embedded in the dashboard as a DHIS indicator. And what is very clear from here, and if you had written your number down for what your case fatality rate was in your inpatient facility, that they have now got threshold markers for poor or unacceptable. So I wanted to just ask you then, if you got this already and you've got the numbers written in, and the reason why I'm asking you for this is I want us to think through what it actually means. So if you're seeing in your facility a case fatality rate, which I call the residual mortality, that means after all the things that you have done to reduce mortality, you're still seeing a case fatality rate about 10%. What more can you do to squeeze the case fatality rate further down below 10%? So this heuristic, this table was conceived in 2016, 2017, if I remember, in Mpumalanga, when we did some of the analyses with the cohort of in-service trained doctors and nurses and dietitians. And we came to a consensus agreement that if you're above 10%, you are in the red zone. And that means that your adherence to inpatient protocols, which are your 10 steps, is poor. So focus on making sure that that is completely closed and it's above 90%, 95%, etc. If it's 5 to 10%, focus on making sure that the emergency case management and HIV readmissions, HIV patients and the readmissions that come back are sorted out through the interventions that I've listed on the right-hand side. And if you're less than 5%, now we need to start thinking about, why is it that the tap is still open? And if the tap is still open to kill children, we need to go out and prevent acute malnutrition through high levels of coverage of our interventions. I'm going to be running out of time. Can I just check with the chairperson that should I continue or should I pause?
No, you can continue. You do have another few minutes.
Okay, thank you. So I have a few agitation type of questions, and if you interacted with me previously, you will know that I will not give you a straightforward answer for many of the questions that we may still have. So let me ask us this question. This is really a true and honest question. Why do SAM cases really die? And most of us will sort of think through a clinical lens or a medical lens, and we would ask questions like anemia, shock, infection, electrolyte dehydration, hypothermia, and hypoglycemia. Yet we know that there wouldn't be a single nurse or a doctor that is unable to manage any of those cardiometabolic problems or infectious problems. But the reason they actually die is because of inappropriate management, not case management, inappropriate systems management. And I think this is an area that needs to be highlighted, which is now encapsulated in the 2024 guidelines as well. So another tongue-in-cheek, South Africa, the reality check for South Africa. So it's not really a bad place to die. If you compare us to other African countries, honestly, we have a lot going on for us. And we still see if you already written down your number for case fatality above 10%, then we shouldn't be seeing these avoidable deaths happening in front of us because we have a poorly managed system. So just to bring it back home, and the guidelines have been kept to a bare minimum. And if these 3 steps are done clearly and distinctly and reliably, I think there is no question that anyone that is in this platform today will disagree that the 10 steps actually have helped children with doing less and getting more. And I think that is the area that I think we should be focusing on as we go along. So I've listed about 7 or 8 controversies. So why are SAM cases so special? Why are we even sitting here and trying to understand SAM as a different entity? So imagine you are a neonatologist, right? And you're working with neonates and prematurity and the low birth weights and the asphyxiated babies, etc. Those vulnerabilities that happen in a very immature baby or an immature life is exactly the kind of physiological changes that happen in children with SAM through a process called reductive adaptation for energy conservation, right? So we are talking about SAM as a special case because what we do for normality, for normally nourished children, cannot be transliterated into a case management approach for SAM. And there's a whole literature behind that. The second one is, why make a big deal about case management? And the thing is very, very simple to understand. If you think through this a little bit, is because we have failed prevention, and as much mortality is high, especially if case detection is delayed. So if you're thinking through this very deeply, case management only comes to you as a condition because the precursors of this condition have been neglected, which is growth monitoring, early detection, checking for edema, and looking for wasting using a MUAC. And we also know that standard W treatment guidelines saves lives. And study after study after study, even in your own settings, if you do it properly, that you will notice that you will reduce case fatality rates by 50%. So the other controversy is definition of acute malnutrition versus chronic malnutrition. Where did this word acute suddenly enter the vocabulary? It was first called Waterloo classification, Kwashiorkor, marasmus. So the idea behind this was to enlarge and broaden the scope of case definition and not just the syndromic bipolar ends of acute malnutrition. One end is edematous malnutrition, the other end is severe wasting or marasmus, and then something in between would be marasmic kwashiorkor. And these are acute weight loss. So if you just think through it and ask, acute meaning what? In the last 6 weeks that the child has lost a lot of weight, that indicates that the child is at risk of dying. Actually 6 to 7 to 8, sometimes even 12 times more likely to die than a child that hasn't lost any weight in the last 6 weeks. Chronic malnutrition is then used as a juxtapose of that, in the sense that it is persisting over a long period of time, and the child can have acute bouts of malnutrition, of wasting, but because he's spending more time being ill and malnourished, he actually is getting stunted and not linear growth occurring. So I think what is necessary to understand here is that we are now broadening the catching of the case early. this has been a controversy like you can't believe. If you read through the journal articles, you will understand why. Some people are pro-MUAC, some people are against MUAC, some people are just adamantly towards weight for height measurement. I think in South Africa, we have chosen to go both routes, and we are going to be using both routes to enter the children into care and exit the children out of care. And both of them predict mortality quite well, but the MUAC predicts more likely probability of dying than the weight for height does. And as you can see as well. So what is the evidence for the 10 steps protocol? Many people challenge
You
the
just have 30 seconds. Sorry to interrupt.
Many children, many people have attacked the 10 steps, but every time there's an attack, they always come back to the point that unless we have a replacement for the 10 steps, we cannot discard it. So I think it just works, so we'll keep it like that. Can we rely on anthropometric failure alone for SAM definition, or can we use clinical features? Sometimes you'll see that the child hasn't got any anthropometric failure, weight for height or MUAC, and there's no edema. But the child looks funny, like subtle hair changes, moon faces, some wasting of muscles in the big girdles, angular stomatitis. Those are SAM patients. I call them SAM in evolution. And if you don't do anything, you may not get there. So why are there no clinical trials that are well designed to test the recommendations of the WHO? For example, the fluid therapy for SAM has been a controversy ever since the SAM recommendations have come about. 2 new studies have just been released, one in 2023 and the other one now in 2025, in last week published. And I would suggest that you go and look up what is going on with them. Last 2 controversies, how about those children who are classifiable as SAM anthropometrically, yet are not managed as SAM with the WHO protocol, such as CPs, cardiac cachexia, renal disease, etc.? The answer is very simple. If you use the WHO nutritional therapeutic plan, you will kill them because they have high protein levels and the kidneys won't be able to manage, right? And therefore, you need to seek case-based clinical case management for this. Lastly, this one always comes about, should I still report the anthropometric failures to DHIS? The answer is the overwhelming yes. Why? Because you'll get more money. Simple. Right. The last one is, why are some SAM cases not overtly SAM, right? Anthropometric definition of clinical edema or low albumin state offered ICU levels of care when they are critically ill, right? And we specifically talking about the SAM who has serious physiological derangements, but we're not talking about that particular SAM that has been refused into ICU for further management. And I would recommend that you look through the set of recommendations that are in the guidelines, as well as some of the literature that I've cited here that addresses some of these issues. And then last one, obviously, Spey will also speak to this in direct terms, but I just wanted to agitate us a little bit to think through what it means ethically and legally to refuse ICU admission for a child who needs ICU care. In the WHO, we have a critical care pathway. We have many of you may have seen that clerking sheet that we've been distributing, and it's also in the 2015 version. They've removed it from the 2024 version. This is a clerking sheet that instructs us on how to monitor the child when he's on IV fluids, when he's on nasogastric feeds, and how much feeds to give him, and the temperature and the sugar monitoring, the respiratory rate, and so on. It's almost like a pseudo ICU setup, but not called ICU. And that's because many African countries don't have access to a privileged access to the pediatric intensive care. So I'll leave you with those last controversies, and thank you for your attention. And I hope you have many questions at the end we will try and field during this session. Thanks.
Great. Thank you so much for that great overview and introduction. So I'm going to go straight into Siebrich's talk. So Siebs, we can start sharing. And I see already there's some nice comments going on in the chats. We will definitely get to that. And I hope Siebrich is actually going to answer some of those questions already. Great. Over to you, Siebs.
All right. Thank you so much for the opportunity to talk. My name is Siebrich Tiemersma. I'm a general pediatrician from a regional hospital in KZN. And I'm going to present very briefly about the inpatient care for SAM. And originally this had the title of Uncomplicated Cases, but I realized no, SAM is actually uncomplicated. So I'm going to present two cases. The first one is focusing on first aid and resuscitation, and the second one is going to zoom in on the management of children under the 6 months age category. So we're going to dive straight into the first case. It is baby AM, a 9-month-old female. She was an ex-prem, 33 weeks with a very low birth weight of 1.37 kgs. Mom was HIV positive but RPR negative, and she had an uncomplicated neonatal stay for 1 month and was discharged from the follow-up clinic. Immunizations are up to date, and the maternal viral load at birth and admission was lower than detectable level, and all the baby HIV PCRs were negative. The mom was advanced maternal age of 41 years old. She was a para 5, completed grade 9. She has received an Implanon. The dad is 45, supported but unemployed. They have formal housing with pipe water, and the income is less than 1,000 rand a month. The child is on support grant, and the mom is still trying to breastfeed. She introduced soft diet at 5 months, but the diet has got no protein. So I was admitted with a 3-day history of vomiting and diarrhea. There was no history of herbal medication given. Was seen at the clinic 2 days ago and given ORS and discharged. The vitals are noted here, but clinically the child was in severe dehydration with shock. Capri full of less than 4 seconds, cold peripheries, sunken eyes, but no edema. Very irritable with clinical features of SAM, but no dermatosis, and had ongoing severe losses. These are the growth charts for the child, as also presented in the Rota Health card. The child had a MUAC measured at the age of 6 months, which is corrected 4 months old. It was 13 centimeters. And on admission, corrected age 7 months, it was 11.3 centimeters. And as you can see on the left hand for the weight for age, she had a curving down growth trend there. And the weight for length was also crossing 2 centiles. So she was diagnosed as a SAM based on the MUAC of 11.3, so just below. Started on the SAM protocol and our MDTs got involved. She was also diagnosed with an acute gastroenteritis with a hypovolemic shock, for which we gave 1 mRL bolus and then 20 mL per kg per hour of Sorrel, ORS, over 4 hours. And we actually repeated that once. And then she had Sorrel after each loose stool. She also had a UTI. On the culture, it showed an E. coli with some acute kidney injury and an hypokalemia, and also a microcytic anemia. So, talking about the 10 steps, what do? So in the first 30 minutes, we're checking the GM, we're checking the temperature, we're treating dehydration and shock. And we also already have to start a stabilizing feed. So this has to happen within the first half an hour. If the child is drinking out of its own initiative, it's fine to do it orally. Otherwise, we have to put an NG tube. And I've already made the micronutrient deficiencies orange because that is included in most of the standard formulas used in South Africa, like the F75. But before we get there, in that first half an hour, we also need to assess, are there any medical complications? And I presented them here below in blue. There are a little bit more than these, but these are sort of the important ones. And why do we use these medical complications? To determine the management. Can we do it as an outpatient, or does the child need admission? And we also use them to determine our prognosis. They are aligning with the IMCI danger signs. And I've also written here that the child needs to pass the appetite test. So in the new new IMM guidelines, apologies, there is a nice appendix and where it will be demonstrated how to do this appetite test. But I know it's been well known for years already in South Africa. In KZN, all children with SAM will be admitted, whether or not they have medical complications or not, according to the previous guideline. So we will see with the rollout of the new guideline what will happen. But I know in other provinces, many patients can be managed as an outpatient. The other one that is really difficult is how to assess dehydration and shock in SAM, and this is not easy. So the classical signs of dehydration are unreliable. Your skin pinch is often positive. Your eyes are often sunken from loss of subcutaneous mass. What about assessing dehydration in a SAM with edema? Maybe they will still have edema, but can still be fluid depleted intravascularly. So that is a tricky one. The diagnosis is often based on the history. You can make a provisional diagnosis, but you really have to observe your response to treatment. So don't walk away from them. When you give even if you give your ORS over 4 hours, you have to check them regularly. So the diagnosis of shock with and without dehydration is still looking at the septic shock, hypovolemic shock, cardiogenic shock, and also you can look at liver failure. And it's diagnosed by the 3 things, also from the ETAD guidelines: cool and cold peripheries, weak pulses, or a cap refill time more than 3 seconds. If you want to know more about this, I also refer to the same guidelines as already mentioned by from Prof. Golden. They've had some more information about this. So shock in stem with and without dehydration. You can start with an MRL bolus of 10 mils per kg over 30 minutes. So not over 15, over 30 minutes. And then you can repeat that if you have to. But after that, you don't have to give any IV fluids. You can go straight to giving ORS, oral or versus NG tube. But you need to start your F75 also straight away after that. And I put RUTF in brackets because most of the kids will probably be too ill to eat themselves. So when do you not feed? While you're correcting the shock, or if there's an acute abdomen, only in those 2 scenarios. So continuing with our protocol, we now end up sort of after the first 30 minutes, we are now in the 30 to 60 minute slot where we have to treat the infection. The antibiotics have to be in within the first hour. You can do it orally if the child is taking it well and doesn't have any medical complications, or you can do it as an IV. And then the next step is also that you're going to look at your electrolyte imbalances. If you're admitting the child and you're doing bloods, then you can check those results. But the admission, if you're admitting to the ward, needs to be within 2 hours from presentation. And then later on, after you've stabilized the child in the ward, days later, you'll start transitioning the feeds and getting to catch-up growth. Step 9 is loving care, play, and stimulation, and preparation for follow-up. And we'll go into a little bit of detail that later. So in this case, the progress in the ward was that the patient recovered, the GE resolved. We changed first to F100 and then transitioned to RUTF once the child was passing the appetite test, had good weight gain, and was discharged. So classically, you go from F75 to F100, and then you start introducing your RUTF. And you start your food once you go to F100, but probably you can also go directly from F75 to introducing RUTF. And also, if you want to know more about this, I refer to an excellent SAPA webinar from 2 years ago by Prof. Lala, who has a lot more information given about that. Okay, let's go to case number 2. This is focusing on STEM diagnosis under 6 months. And as already just mentioned by Prof. Corcelli, we are starting to change the guidelines and looking more into this really vulnerable age group. Going to start using the MUAC from 6 weeks to 6 months. And the cutoff that we will use is 11 centimeters. And the other thing is, as mentioned, the weight for length. If it's less than -2, the child also needs very careful observation and probably admission. So recognition of infants is stimulated. So look at the children that are at risk due to poor birth outcomes. And we know this. We know this group is really vulnerable. Our low birth weight babies, our prints, and also the one with known risk factors for poor growth. You know, when there is already a risk factor for the moms. And we are good in recognizing this group. So we also need to now enforce this and do our follow-ups and do our interventions. We have to recognize the kids with poor anthropometry and with poor growth based on sequential measurements. So we really are not going to see this. And a disclaimer that I forgot to give is that all these cases are actually from the last weeks, from the last month in our hospital, including this growth chart. So we really don't want to see this anymore, where we're only picking it up on after the age of 6 months. So this baby is baby SM, 5-month-old female, was also an ex-prem, 32 weeks at a district hospital, was born with a very low birth weight of nearly 1.4 kilo as a BBA. Mom was HIV and RPR negative. She was a grade 1. It was a teenage pregnancy, 17-year-old mom, uncomplicated neonatal stay, and was discharged from the district hospital at 1.7 kg. So immunizations are not up to date. Mother is currently in grade 9. She chose Depo as her contraception. She's living with an aunt, a 34-year-old, and the father is 25 years old. They have informal housing, no pipe water, and the income is less than 1,000 rand a month. The child is not on support grants. The story is that the computer was offline the first time she went. The second time was too full. She stopped breastfeeding at the age of 4 months due to low supply, and now we know that she was mixing formula incorrectly. The last herbal enema was given in March, according to the mother who is the caregiver. And she traveled the day before the admission to her mother, so the maternal gogo, and the patient was found to be ill. The patient presented with a one-day history of fast breathing, was hyperthermic, had sets of 80% in room air, and was tachycardic. The baby was unkempt with cool peripheries, delayed cap refill, so was in shock. Severe dermatosis with a severe impetigo, an epi rash, severe dehydration, severe respiratory distress, and lethargic. The growth was not really measured, but we know at the age of 2 months, when she went for a 6-week visit at the clinic, the MUAC was measured and was 6 centimeters. And the child was seen by a dietitian and extensively counseled, but it was the last notes in the Road to Health card. And at the age of corrected age of 3 months, she presented to us with a MUAC of only 7.5 centimeters. Now she totally falls off all the growth charts, and as we plot her on the weight for length, we only have the one measurement from the admission with us, and she was too stunted to fit on this chart before that. So we diagnosed her with growth failure, severe acute malnutrition without edema. She was started on F75 in the SAM protocol. The acute gastroenteritis was actually not recognized by the mother, but she was severely dehydrated. In shock, we gave 1 MRL bolus and then gave ORS 20 mL per kg per hour for 4 hours. Also had a UTI with an E. coli, a severe anemia of an HB of 5.7, for which we gave a transfusion because we thought it was symptomatic. If it's below 6, you can do that. Severe pneumonia was confirmed on the chest X-ray, and we did some tests. The PJP came back later as negative. She was rhinovirus positive. The CMV, IgM, and IgG was positive, but later on we know that the viral load was actually quite low, and the TB NAT was negative. So what did we do? We started high-flow nasal cannula, and we started very early on already making a palliative care plan, and we decided this baby will not be ventilated. We gave antibiotics, and we had to change the second line. When we first had the CMV results, we started ganciclovir, and before we had the PJP results, we started Bactrim and also fluconazole, and we started morphine for comfort. We counseled the family, including the grandmother and the patient demise on day 5 of admission. So we recognized many risk factors. It was a teenage pregnancy. She was staying with her aunt, away from her own mother, infrequent clinic visits, and a preterm delivery. So if you look at all the determinants of malnutrition in South Africa, there are so many, and there's so many factors that we as clinical healthcare workers actually probably cannot change. What can we do? And what we can probably do, and I just want to give you guys some ideas about what you can do is, and put more focus on, is on step 10, prepare for discharge, because there is some more things that we can do also in the hospital. One of the things that could work well is organizing a good MDT group where you do a bedside MDT rounds. We have our local IMA meetings where we all sit together with the MDT team, but also we can invite people from the district to come. Our speech therapists, OTs, dietitians, they do in-service meetings with the caregivers in the ward and take their time to explain. Stimulation and play. Organize your SAMs in a separate ward, as has always been done. Doing like toy making projects where you make toys with the kids, book and toy donations, or fluffy toys to put in the bed. From the district, you have to link to the clinics, OMs, or with the outreach teams. The home visits need to be done by the community healthcare workers, and we need to give feedback, and that system can use strengthening. District meetings where you present your difficult cases or for cases to be followed up at the clinics. Family meetings can be really encouraging because we can invite the family and together maybe appoint a different caregiver. Disclosure of HIV status of both mom and the baby is really helpful, and we really facilitate and put a lot of emphasis on this. And we can assist with grants. We've got a good contact at the Department of Home Affairs where even if the child is still admitted, we do want to make a change that the baby goes home and there is something different when they go home. The mother, of course, we check her health, we check her viral load, if she's got enough TTOs. Long-acting reversible anticonception is also given. We have a discharge checklist that we developed to check if we've done all the steps that we want to do. So not just the 10 steps for the IMN, but also all these sort of quality improvement projects. Form 22 I've written there that is sometimes can be helpful if you have kids that need to be placed and that really cannot manage by their own caregiver. And the one thing that I highlighted here is our food parcel donation project by a local NGO that has really made a difference in our readmissions of SAM. So by cooperating with the local NGO, we are able to give them food parcels for 3 months, and the patients actually come back for follow-up. And I want to leave it at that. Please, if you have more questions or ideas, feel free to contact me.
Thank you so much, Sips. That was great and quite a mouthful. So thank you for doing that. I see there's quite a few questions in the chat, and maybe we can just get to one or two of them before we go over to space talk. So one of the, I think, very fair questions is sometimes getting the IV line in the first hour is difficult as they have edema and it's busy. Would it be okay to give a dose of oral antibiotics and then get up the IV line for IV antibiotics? Sipta, I don't know what you think about that.
Yeah, I think you just have to be practical. Yeah, if the baby is vomiting, then obviously that might not be a good idea. But if you can put an NG tube and it's like a fluid, it's like a resuscitation, maybe of a low GM. If you can't get a line and you don't have an option for an intraosseous, then you also, like we also advise our clinics to do an NG tube and at least give a correction via the NG tube. So I don't see why not. I'm not sure if the other experts have any idea.
No, I think it's fair. I think you have to give it at least 1 or 2 tries and see if you can get it up. Obviously, if you see this is a desperate situation, I agree, oral is at least an option. But I think the other things that you mentioned, you know, the basics, checking the glucose, make sure the temperature is okay, make sure that first feed go in. All those things need to happen, and we shouldn't just like get so distracted sometimes in getting that drip up. There's a lot more that we can do while we actually get the drip up. So I think that would be from me. I don't know what you think, Prof.
Absolutely. And I think the question is a double-barrel question. The first thing is that why do you want to put an IV line? Right? So that's the first question. Is this child so sick that he needs an IV line? SAM children are sick generally, but we say that you only put an IV line if you are in shock, meaning a running line. But I think they're talking about a short line for IV antibiotics. So what studies have shown is that even cases with 2+ edema and going home, we are the only country that admits edema patients, by the way. Other countries send them home on oral antibiotics and close monitoring through a community health worker. So that those studies show remarkable recovery rates of more than 85%. So the answer is yes, put a nasogastric tube and feed the child. But focus on making sure that he's warm, he's fed, and he's receiving his antibiotics. Thanks.
And I think what Dr. Alma was saying in the chat as well, you know, actually giving an IMI dose of ceftriaxone initially, if it's really a patient that you're worried about sepsis and SAM, then giving us that dose of IMI ceftriaxone while you get the drip is actually also a very good option. All right, so there's lots of questions. Keep them coming. But for now, I'm going to hand over to Dr. Hlophe, who's going to talk about this very controversial topic about, you know, ICU care. Why do we not admit these patients to ICU? And what if it is in the ideal world? And do we have some guidelines around this? So thank you, Spe, for taking up this very hard topic. Over to you.
Good afternoon, and thank you for the opportunity to present. I'm Dr. Sibegazelo Hlophe. So who is the complicated SAM? So as already been mentioned by the 2 speakers, is actually one of those patients that won't really respond in the usual 10-step of management. So the child that is coming in with diarrhea and then severe shock, that you've already started giving them IV fluids. So how far can you go with the IV fluids? Initially, we said you can give 2 boluses and then go to NG. But if they're not responding or they're still vomiting, what can you do after that? So those are the patients that I'm going to be focusing on. Whether do we put them in high care, give them an ICU bed, and what is the outcome of those patients? Just a bit of a background. So malnutrition is one of the very common conditions that are seen in patients that are critically ill. It may either be due to the pre-existing nutritional deficiency, or the severe illness itself can push the patient into severe acute malnutrition. It is usually mostly underreported in our hospitalized patients, either because we don't do a proper nutritional assessment on admission, or if we do it, it is not documented at the right place. We sometimes go through the pages of the file to find the height so that we can plot the patients. So that's why these patients are usually missed during the admission or over the course of PICU admission or pre-admission, actually. Even though worldwide it has been reported that the under five malnutrition has actually reduced by a third compared to the previous years, but in South Africa we're still seeing patients dying from severe acute malnutrition. So this is why this topic is really important, that we are able to identify these patients early and we give them appropriate therapy. We are trending for the wrong reasons as a South African country. So we are among the top 20 countries that are actually still have more than 65% of children living under severe childhood poverty. And unfortunately, 23% of these patients in our country are in that category. So these are the patients that are really don't have adequate intake, and then they present with severe acute malnutrition, or even if they present to the healthcare facility, they're not attended early and they're missed, and then you end up finding them later on with complications and then poor outcome from that. How common is malnutrition in ICU? It can range as low as 7%, but as high as 78%. So it is very common, and it is usually, as I've mentioned earlier, it is mostly underreported, underdiagnosed, and undertreated, but it is very common to see a child with severe acute malnutrition. Poor nutritional status at admission or worsening nutritional status during the course of admission has been reported to be associated with poor clinical outcomes in these patients. And those that have severe hypoalbuminemia, that's a one independent predictor of 28-day mortality, and also sepsis occurrence in those patients that are admitted in ICU. But not saying that hypoalbuminemia should be used for nutritional assessment or as an indicator if the patient is acutely malnourished, because it can be affected by many things, and it is a non-specific marker, but it is one of the key predictors of mortality. So what happens to a patient that is malnourished? Most of the patients have increased catabolic stress, and they have increased inflammatory responses. So these patients end up having consequent complications of that, which is muscle loss, muscle weakness, and as a result, multi-organ dysfunction. Because the weak muscles, then they have reduced respiratory effort, pulling of secretions, pneumonia, poor muscle strength or muscle loss, weak cardiac function, and then complications as such. They also have a suppressed immune system, and then as a result, these patients are prone to developing infection. They are at risk of poor or delayed wound healing. Even if they go for the simple procedure, they have a higher risk of poor recovery process, and then they stay longer in ICUs. Because of the weak suppressed immune system as well, it is sometimes difficult for them to mount the immune response. So even if they have infection, they may be delayed. It can be delayed picking up that infection because of their response to the infection, and also because of the delayed detection. Then there's a delayed treatment, and then there's a poor outcome from that. They have increased risk of infection, poor intestinal absorption, thermoregression is a problem, and all the other organs are really struggling because of the suppressed immunity. So what is the effect for the facility? As it is, we are struggling with the resources in the institution. So now if you're admitting the patient that's going to be at higher risk of hospital-acquired infection, that means more medication is required by this patient, prolonged ICU stay, prolonged hospital stay. They develop pressure sores because now of the prolonged stay, the risk edema, and then high risk of pressure sores, and then they stay longer. What does this do? It also increases the cost that the hospital now had to undergo for that one patient. Other short-term outcomes that are associated with with malnutrition is increased mortality in comparison to the patient that are admitted without malnutrition or mild malnutrition. They also have a prolonged requirement of mechanical ventilation. They have increased PICU stay. With an increased PICU stay, as you are aware that there's now increased hospital-acquired infection, longer hospital stay, and then all the negative PSIs associated with that. They also have a really decreased likelihood of getting discharged because of these complications that are associated with malnutrition. They have free ventilator-free days, even if they have acute short like surgical problem, they can complicate and then stay longer in ICU and then develop hospital-acquired infections. Long term, if they are able to get discharged from ICU into the ward, they have a higher risk of having poor growth and development, poor quality of life. They have impaired function, such as cognitive and as well as physical function. So these are the patients that really need a parent or a caregiver to be there for them 24/7. So they really struggle even after they survive ICU or hospital stay. What about those that require surgery? Are they at risk of the similar complications as those patients that are admitted with medical complications? Yes, they are. The malnutrition in a surgical patient is an independent risk factor for high morbidity, mortality, prolonged length of stay in a surgical patient. So it is very important that these patients, surgical patients, are assessed for nutritional status. And if they are found to be malnourished, then they get an early intervention to resuscitate nutrition first, if possible, before they embark on taking them to theater. Because post-op, then they will complicate with poor wound healing, poor recovery. They have anastomotic leak, wound dehiscence, and then they go back to theater multiple times. They develop infections. Also in the surgical patients, this is really underdiagnosed and undertreated. And unfortunately, sometimes we see these patients post-op because they were not assessed properly pre-theater. And then unfortunately, because of the malnutrition, then they have lots of complications that are picked up post-op, and then that's a problem. Especially for the elective cases, it is important that no patient should go to theater without having a proper nutritional screening and nutritional intervention before they go to theater, because we're trying to avoid or limit the risk of the morbidity and mortality associated with malnutrition. There is very high risk of negative events if the patient is taken to theater without having a proper nutritional resuscitation. And if they survive the ICU, the chance of readmission is very high in these patients. So they really need to be resuscitated if they need to go to theater before they are taken to theater, because they are really at higher risk of mortality and increased length of stay. Just few studies that looked at mortality in patients that are malnourished and admitted in ICU. It was found in one of them that the patient that are admitted in PIDS ICU compared to those that are well nourished, they actually have a relative risk of 1.33, which meant that they have a 33% increase of having a 20-day mortality compared to the patients that were well nourished. And also another study showed that they actually had more than double the rate of having high mortality compared to the patient that were well nourished. Even the post-op patients that are admitted post what is thought to be an elective procedure like post-nasal application, if they are not well resuscitated in terms of the nutrition pre-op, they have an increased risk of mortality. Even the patients with other interventions that are required in theater, such as chronic renal replacement therapy, if you're comparing those that have malnutrition versus the ones that have a normal nutritional status, the mortality there is high as well. Just one slide looking at what is the PICU access looking like in South Africa. So the one study that looked at the 1-year duration in Albert Luthuli showed that the patients were, 33% of the patients were refused PICU access or denied PICU access because of the bed unavailability. And that also is similar to what was shown by the longer duration, which is not published yet, but we looked at what is the access rate like in Albert Lutuli. So 33.7% in that time frame were denied a bed because it was not available. In Grace Hospital, currently also over the last few years, our mortality, as you can see on the graph on my right, it shows that actually the refusal rate has gone up to 49%, and it started increasing over the last 3 years because of unavailability of beds. Another study in Nelson Mandela Academic Hospital, also it was a short duration, but you can see also that the refusal rate there is also high. And the main reason for all these sites, it was unavailability of bed. And one study that was done at Barra Hospital, this one was looking at the patients that were initially admitted to high care because there were no beds available in ICU to check what was the acceptance rate now from high care to a proper ICU. And there as well, they reported that only 69% of those patients that initially required to be ventilated in ICU, but because of no beds, they were ventilated in high care. So the acceptance rate there as well was 69%, which is a problem because you can see that all over the country, we're really struggling with PICU beds. I looked at some of the admission criteria in different sites, so PMB Complex, Critical Care General, and Red Cross Hospital. So what the admission criteria state is actually similar throughout these admission criteria. It states that the patient that is a suitable candidate for an ICU is a child that is an acute, life-threatening, and physiological compromise, which is deemed reversible with available resources, knowing that we have really limited resources. The patient must have a good outcome if they're admitted in ICU, and preferably a short ICU stay so that you can be able to admit more patients, as we've seen that we're really struggling with the ICU beds. So if the patient is not going to be benefit from what we have available, then what's the point of admitting them in an ICU? Actually, it was in one of that admission criteria, the state that if the patient has a poor prognosis, then they'll just block a bed for another patient that has a good outcome. So unfortunately, one of the patients that are deemed poor candidate for an ICU admission is a child with severe acute malnutrition. As it was stated earlier by the two speakers, actually with a patient that has severe acute malnutrition, the less is better. So we need to try to screen who can be offered an ICU bed or a high care bed. But as it is with the mortality that is high, morbidity, length of stay, limited resources, the patient with severe acute malnutrition won't benefit from being offered an invasive therapy in ICU, which include ventilation, renal replacement therapy. All those things will actually be not in the best interest of a child if you admit them in a PICU ICU. What about a high care bed? Do we have enough? And who can be admitted, who can be considered for a high care bed? So a patient that is shocked, that has been given adequate fluid, that is still vomiting, that cannot be transitioned to an oral or NG feeds, may be considered if the resources are available for a possible high care bed, just for inotropes and close monitoring, but not for invasive ventilation or other invasive procedures such as renal replacement therapy. With that, I would like to conclude and say malnutrition is a problem, and especially for the critically ill patients in our setting with limited resources, it is associated with poor outcome. Unfortunately, it is mostly underdiagnosed, undertreated, and it is a silent epidemic, especially in those peri-op patients. Now they've already suffered the stress of being involved in a surgery, and then already their body is weak, and now we see the outcome of them that actually they do poorly post-op. What is important is to identify these patients early, preferably at the PHC level. Prevention and promotion is better, and identify them early, offer them a proper nutrition. If they require intervention, make sure that you resuscitate them adequately, nutritionally, before you consider taking them to theater if they require theater. With our limited resources, we really have a strict admission criteria that needs to be followed, so we can only admit those patients that have a better outcome, reversible cause, shorter duration in ICU. And it is really important to have admission policies, that is, admission policy that is strictly followed, especially with our current state of limited resources, and that we are failing to meet the demand that is required by our critically ill patients. Thank you. I will now take questions.